back in 2013 by the team. We did another position. And when I experienced with combination of the vaginal rejuvenation, which is actually progressively increasing in Asia, because I traveled internationally, Asia, Australia, now coming to United States. So we need to create awareness that women are actually, in real self, you would notice that patients and consumers are actually asking for this right now. And so, especially with the Me Too power, and not that I'm sounding like a feminist, but women are empowering themselves, and this is part of it, for combining the PRP, OSHOT, or I call it sex stem cell or feminine rejuvenation, and you combine that with the platelet-rich plasma. And I'm so glad because I had the chance to also have a different site, a different machine,
System, right.
a different system, which just gets about maybe 10 ml, and they spin it. But I saw the difference because when I treated this patient, she had an OSHOT, and I recalled him after 12 months. And I redo and use the M-Site system. And she right away called me within 2 days. She said, Dr. Maxino, this is definitely way different than the OSHOT that I got when you use another machine. So just from, perspective of using two separate machines, it makes a big difference. So I look forward to seeing the numbers and to participate in the program that you have, Lisa.
And to further that point as well, Dr. Maxino, is, and where did you get your information on what PRP kit to use or what PRP system to use? It's really from the salespeople out there.
Yeah.
So it's so important for us to create this opportunity for you to get this information from real experts. I mean, everyone's training in PRP and everyone's selling the best system. The fact of the matter is there's not a lot of great systems out there. So you really, and that's what the company's all about. That truly is. And I've privileged to work with hundreds of physicians and to be able to focus in on these experts who have committed them to the patients, committed to themselves, and to bring this forward in the most proper way. And with that, let me just go back and make sure I thanked everyone. And Alicia, I could never have done this without you. Thank you so much. She's my right hand. We do have hands-on training programs and private training programs throughout the U.S. We are specializing in these trainings, and small group hands-on trainings. You can't get this type of information or clinical training anywhere else. I know Lisa often has doctors come to your trainings that say, I've been trained by this one, I've gone here, and then they end up with us. It's because they just can't get the right information. And I am excited to announce that Dr. Bano has created a very comprehensive online training course on male and female sexual wellness. We're holding back and launching it. It's coming very, very soon. But that's exciting on the front. There is some training out there, online training. I don't know if anyone has seen it. Reynolds has one, and we respect Reynolds brought this to the market, but there's nothing quality out there in this training. And really, you may want to speak to this, Dr. Urbano, instead of me. What was the reason you wanted to develop an online training course?
So that there would be some standardization. And I think what Dr. Bukic said, if we get like minds thinking alike, people come to me and, so I'm known in Peoria, Illinois as an ED expert. And, then when I started with platelet-rich plasma, I had to make certain that what I was doing was not going to hurt the patient, because eventually it would hurt my reputation. So I looked long and hard and thought about it. And very quickly on, I saw the benefits, and they've been very positive. Again, it does not work for everybody. But for the ones that it does, it has saved them their marriage, their partnership. It saved them from having surgery, which I'm not opposed to. But if I'm sitting in that chair and the patient tells And I say, well, you can either have platelet-rich plasma, shockwave therapy, or you can have a penile implant. These individuals, if they financially can afford it, are going to choose to have the least invasive procedure. And I had 2 patients the same day. One said, definitely, that's what I want to do. And in the afternoon, the other patient said, sign me up for surgery. So everybody's different. But I think that you have to respect their wishes, you have to respect their financial ability, and I know that no time soon is any of this going to be covered by any type of insurance. So I think that, so if I can enjoy success in Little Peoria, Illinois, people who, like Lisa in New Hampshire, now I have another small town to look up to. So I think it's nothing for Dr. Shenvan to be right here and create a solid product. He's a young man and he's got years ahead. And I think, developing the specialty and doing it, in a logical, stepwise fashion is going to bring all of us success.
I can speak to, again, I don't bill insurance. We are strictly cash pay, out of pocket. But I just want to mention that we've had absolutely no problem getting these procedures covered by flex spending accounts, health savings accounts. Run the card, tell them, what it's for. We don't do any insurance billing, but a lot of people out there have those, type of options open to them. So I always try to mention that in my trainings as well, because I know it's hard if you're sort of in a more traditional practice to wrap your head around these, procedures that you're going to bill out of pocket. But people have that option. There are also plenty of companies where, you can offer them, 12 months interest-free without any money out of your pocket, actually. There's one called Advanced Care Card, if you don't know about it. Doesn't take anything from the physician, but gives the patient 12 months to pay for their procedure. And there's no retroactive, like if the patient at 12 months has like a $400 balance, right? They don't go back and whack them for the interest from the beginning. They basically say, okay, you got $400, we're going to pay interest on that going forward. So those types of financing options are just something you need to make your patients aware of and know about yourself. Sure, you take Genevieve, we charge Genevieve plus the O-shot $3,300. People come up with that all day long because this is critical. This is life-altering, and it works. And we've got, video testimonials, and we've got, verbal testimonials, and we've got any number of, home runs and it's an amazing field to get into, and I think everything in the market is saying that more and more people are going to be seeking out these treatments. So if you're not already doing these treatments, if you have any interest whatsoever, you really need to research, the technologies that are out there and think about, getting into this even though it isn't covered by insurance, because it's vital. Women need it. It's the first thing I ever did a commercial for. Honest to God, I was never thought I would do a commercial, but we have a commercial and it plays on the New Hampshire Evening News, and I'm almost need to clone myself. So, and honestly, think about it though. Women come in to me and they're like, why? I have been complaining for 5 years. Right? 5 years, I haven't been able to have intercourse. I've been crying, I've been complaining. Every time I'm in there, why didn't they tell me there was something I could do? They're furious.
And in all fairness, you're not taught that in medical school, right?
Right.
I mean, that's not the approach. This approach is so completely different. And as far as patients and meeting it and being, they're coming to you to solve their problem.
Right.
They are, and their problems, especially men, are really getting the neck.
Yeah.
I mean,
Lisa said they're going to their gynecologist. I had a patient 3 months ago, saw me because he saw another urologist that he told him he had ED. The guy wrote him a script for a Viagra. He came back 4 weeks later. He said, "Doc, it didn't do anything for me. Sorry, I can't help you." And he left. And he's 50 years old. And he came to see me. And you know what? It was a quick fix. So it's not always the patient who's afraid to talk. It's sometimes the clinicians are afraid to talk. That's the nice thing about having questionnaires when someone comes into your practice. Oh, it's the IA score. Well, geez, they're asking all these questions. I guess he cares or she cares about my sexual function. It means a lot. It's sometimes that's all you need to break the talk and get the conversation going.
And kudos to you for coming here, because that's what you're doing. You're coming here because you want to bring a solution to your patient.
Wanted to add one more thing,
Yeah.
that we are all in agreement that the final count of the platelets is critical to the outcome. There's one thing that we haven't talked about is the injection technique, which I believe is very important. Hormone optimization of the female patient and the male patient is critical as well, especially in peri and postmenopausal women. And one more condition that I treat is lichen sclerosis, which we haven't really covered.
So no one has said it, so I'm happy to say, PRP or Shockwave is not a magic pill, and none of these clinicians are training to a magic fix. They all have integrative practices where they're integrating functional, regenerative, hormones. I mean, they're looking at the whole body, and that's all we want on our team. That's so. It is not a quick fix, and it's a component of a whole holistic approach.
I will say this about lichen sclerosis. I have a number of patients. They need more treatments. At least two. Usually, I usually tell them every 3 months until it, cools off, and that works really, really, really well. They're off all their medications. They're not using any steroid treatments. They're symptom-free. They get a tingle, and they call me. Like literally, they're not going back there. I get the emergency OSHA calls. They're like, "I feel a little funny. I need to get in tomorrow," and I'm like, "Oh, yeah, okay, we're just going to have to make that happen, right? Because you have to." But honestly, in that patient, it can be a miracle. I mean, honestly, it can be a miracle. But it does need more than the once a year. Definitely a few treatments, and then we go according to symptoms, and they won't let it slide.
And we all know better sex. We say you have to have a condition. That's pretty awesome. So, any more questions? Yes.
Hi, I'm Vincent Apicella, DO. I'm here with my team. I'm a physician in West Palm Beach, so we're getting trained tomorrow, and I'm excited. They are.
Thank you for coming. Making the
I'm
trip.
a physician, practicing physician, owner, operator, and also CEO, so I have to ask not so pleasant questions. So being that obviously you guys are very respected and you're doing this, and I'm very appreciative to have your brains here, so I'm going to take the opportunity to ask the questions. It's a two-part question. Number one, how do you guys approach the expectations to your clients? Because we've all agreed already that it works for some, doesn't work for others. So if you could give my team here and everyone else, how do you talk about expectations with your patients initially? And then if you do have one of those clients where things don't work, how can you share perhaps some of your strategies of how you deal with those patients?
Did you want to start?
Okay. So I approach the patient with what their expectations are, and I tell them. Now they'll come to me many times and say, "I want a longer penis. I want a big, thicker penis." And you know what? I tell them, you know what? So wait until I come out with Girth Max in the next 2 months. But platelet-rich plasma and or shockwave therapy is not going to make your penis bigger. And if you use that as a selling point, you're cheating the patient. You have to look objectively. I think that in my practice, I find it invaluable using the IEF score, the laboratory data, and the penile sonogram. It's hard to think about the architecture of the penis without seeing a sonogram. because a plaque that you feel that may be 1 centimeter long may have a branching, and it's 3 times the size. So you just have to be truthful with the patient and give them the odds. You know, I say 80 to 85% success rate, depending on the individual. I may look at an individual and say, you know what, I don't think anything's going to help you but surgery. And you've got to be able to do that. It's not just for the money, because again, your reputation's online. You're the CEO. You want your team the best practices. So that's what I'm saying. You have a patient who is incontinent. Eventually you want a continent patient. And if it can't be achieved, well, we have other things that we can do. We have Botox, we have neuromodulation, you know, we have surgery. I mean, those are things. So you may not do that, but you have to send the patient to someone who does. And that patient will be happy forever, because example, a family physician gets an elevated PSA. He sends him to me. The patient has cancer. He goes back to that family physician. Thank you for saving my life.
Off of his question, so for example, most of the women we're seeing, their main concern is incontinence and/or vaginal dryness. So when we do say, okay, this is indicated or can help that, what are the percentage of patients that don't get reprieve from urinary incontinence and/or how do you gradient, how do you define success for them when that's their, so how many of the patients do you not have maybe success in doing the OSHA and/or don't need?
You know, I think this is a lot like, you know, many things in medicine. I mean, you have to, and I don't know if you also have an energy-based device or you're considering that, you know, as well. But, you know, the more advanced someone's symptoms are, the more I'm moving them towards a combination procedure. And they totally get that. All right, so if I have someone who has, is going through 6 pads a day, I'm not going to oversell an O-shot. It's going to cure that, you know, that problem. I'm telling them, you know, we need to do RF plus, you know, PRP. You know, that I tell them I'm not going to oversell, you know, if you will, the O-shot to cure a problem with libido. You know, it may help, it may not. You know, I use the 80%, you know, success rate figure as well. If it's more than moderate symptoms, we move them more towards, you know, combination treatment. Sometimes they opt to do one and then only add the second thing if they feel they need it. But you can't sell it as a home run for everyone. And you can't do this, you know, money back guarantee, you know, sort of thing. I mean, this is medicine, okay? So if I'm an orthopedist and someone comes to me and says, I have such bad knee pain that I can't play golf, and I operate on the knee, and, you know, they're somewhat better, but they still have too much pain to play golf, you know, all right, I'm not refunding their money. You know, I did what I tell them is, look, we're doing this to a very exact protocol with a very high quality PRP. It's as good as it's going to get. You know, it may be enough for you, or you may need another modality, RF, surgery, you know, something else. What I can tell you is I'm not going to harm you.
Exactly.
You know.
The combination therapy, let's say maybe there's a hair improvement, but not so they're where they want to be. Waiting a full year.
No, you don't need, yeah. We usually have them wait 3 months. So we say, you know, at 3 months, you're probably seeing the most of whatever you did, you know, what it's going to give you. So if at that point, you know, you're better but not great, by all means, you know, repeat the procedure or then do a combination procedure. Oh, absolutely, yeah.
Again, at that point, offer a slight maybe package to say it's a repeat within a 3 month.
Yep, we have a lower price. It especially comes into play with the lichen sclerosis patients who need like 3 treatments. So we drop the fee for number 2 and number 3, and you know this is where also it comes in handy to also do trainings. You know, so you'll once in a while have that person who's like, oh, I'm not over the moon. I mean, yeah, I know it's better. Or, you know, this, that, the other. I was hoping for more. I'm like, well, I'm teaching a course on July 7th. How about you be a model? You know? And this way they're contributing to training, you know, and they're getting an extra procedure. And I'm getting a model out of the deal, which is, you know, cool beans all around. So,
And
you know.
remember, it's your job, I think Dr. Daniel touched on this, but I'll expand, to set the expectation. It's not a magic pill. You know, there's a protocol to follow. There's a post-protocol on a lot of these. That's what they're teaching to.
Right.
A lot of patients aren't following that as well, but it's a whole approach. And combination therapy wasn't even around 2 years ago.
Right.
I mean, they were just using therapy. So it's now we're finding these advances in combination.
That was a very good question. And the way I approach it, I'm careful in patient selection. If they have severe stress incontinence, the O-shot is not going to cure it. And secondly, if the O-shot is done for sexual dysfunction, and after 3 months there is no improvement, I offer them another O-shot at a 50% discount.
Something else that's important, especially when you're first starting, is like anything else you do, there's a learning curve.
Yeah.
Your first 10 more shots are not going to be as successful as your next 10. It's just, there is a learning curve.
But I will tell you, being a part of this group and training with us, and that is the value of this network, is having access to these experts and helping to shorten that learning curve. And I can promise you that. I mean, that's exactly what we've done by putting this together. Where do you get this information? Where do you get the support? You know, you want to do these therapies, where do you go for training? That's what this group is about. So.
I've had physicians call me and say, I'm not having any success with this. How are you even, like, you know, how are you know, and I'll say to them, well, what exactly are you doing? And they'll describe to me what they're doing, and I'm like, that's not the protocol. You know, they're just shooting it randomly, like, you know, wherever, and you know,
It's a whole
it's,
protocol.
right.
It's not just where you inject.
Right. It's not just,
It's very critical.
it's not just put it regionally, you know.
The O-shot is given by physicians that come from different specialties who may not be so familiar with the anatomy as a gynecologist or a urologist. So they have a longer learning curve. We have been working that area for years, so we know the anatomy real well and we know where to inject it. So that's a very important
Right,
point.
and to further that point, Dr. Vano, when he trained on PRP and for sexual wellness, the protocol is quite different. His years of experience got him to his proprietary protocol because he was able to put that experience or match that experience with the treatments. So, great questions though, keep going.
Sorry, I have
Omar?
the penile sonogram. We happen to do general and vascular ultrasound in our practice, so do you recommend we do that on our male patients?
Absolutely.
Is there a different probe that's used, or is it a regular general probe?
It's a regular general probe. I think it's part of my standard workup. And here's another thing that I did not mention. The patient actually sees a sonogram and you explain what's going on. And you say, this is why when you stand up or you change position, your penis becomes flaccid, and you show them that. And then, hopefully, 12 weeks later, when you do the post, you see a decrease in the venous insufficiency and sometimes an increase in the arterial velocity. So I personally believe it's critical for it to do it on all your ED patients.
So I can tell you in 14 years of practice, I've never ordered a penile sonogram, so I'm sure my tech is going to look at me funny, as skilled as he is. So is there a certain technique or measurements that he needs?
So that tech could go to the textbooks and figure it out. So good. I'm sure he'll do a great job. But you've got the equipment, so use it. I think that also, it does give you information knowing which way to go.
And it gives you an edge in the marketplace as well. It's just having this conversation going forward with get started. You know, everyone's in PRP now, right? tangible results. It's.
Well, we need a CBC machine for urgent care anyway, so we have to know which one we're supposed to get for this too.
To answer your question about the vascular, because I'm a sonographer, doctor.
Oh, yes,
I work on a vascular ultrasound machine, a general ultrasound machine. But for that kind of small part, I'm sure you use around 9 megahertz probe, 9 for vascular for coils. So you might need probably just smaller, probably at least a 14 megahertz to see those little vessels.
Don't even know what we have. I mean, we do carotids, so,
I mean, you might see someone who navigates with that, but it's just small areas, so you might probably around 14 megahertz. And we use 18 megahertz, 14, 18 to see, first attendance and all of the hours versus
And if I can mention, the same thing goes for orthopedics. There's lots of doctors that can do an intra-articular joint injection, but can they do an ultrasound-guided tendon injection and really pinpoint the pathology and really get to where they need to get the PRP? And no, that takes another level of skill. And so, yes, an internist could possibly do it, DOs, absolutely. But to take it to the next level and be trained to do an ultrasound-guided injection and really pinpoint the pathology, sets you apart from everyone.
Well, if there's any more questions, if not, I hope you all filled out a survey. But I bow to you all. I know you've traveled long.